how to classify them. So two very simple objectives. The first case is that of a 48-year-old female who presented with chronic dyspepsia, and on upper GI scopy, she had a clean based ulcer of 1 to 2 millimeter in the antrum, and the mucosal biopsy was taken from the antrum. So one thing about the gastric mucosa, there is not, a significant correlation between symptoms and histology, scopy findings and histology. Dr. Desai, would you say that, or what's your opinion on that?
I agree.
Severity of symptoms may or may not correlate with the histological findings. Okay, so this biopsy, who would like to start? Shall we start with Faiza?
Okay.
What are you seeing, Faiza?
It's a gastric mucosal biopsy.
Good.
Right now, I can't see any surface ulceration as such.
Okay.
I can see a moderate degree of inflammation and somewhat expansion of the lamina propria.
Okay.
The glands are like foveolar hyperplasia is seen somewhat.
How do you diagnose foveolar hyperplasia?
The glands are slightly tortuous comparatively.
You mean the foveolae or the glands? So the upper part is the foveolae, lower part is the glands.
Foveolae.
Where is the hyperplasia?
Foveolae, ma'am.
Foveolae. Okay.
Foveolar hyperplasia. Yeah, the foveolae are tortuous.
Okay, good. And the glands? Which
the glands
stomach
also
is
appear.
these glands from? What type of glands?
These are antrum, ma'am. Antral glands. These are antral glands.
Why do you say they're antrum?
Pyloric glands are somewhat pinkish looking glands compared to antral glands, ma'am.
Pylorus and antrum actually is the same. Pylorus and antrum has the same type of glands. So what do they produce?
Body produces acid and intrinsic factors and mucin, ma'am. And pyloric glands here are the parietal and gastrin producing glands, ma'am.
No, the antral glands produce mucus. They produce mucus. See these pale glands. They're pale because they're producing mucus. Mucus has a high water content, so these glands are pale. So this is the antral mucosa showing mucus producing glands. Okay, we'll go to the next power. Okay. What can you make out of this magnification? Surabhi?
Some of the foveolae are filled with secretions. And
what do you mean by secretion? What secretion will they be filled with?
Mucin.
Correct. So can you see, how will you see mucin? What is the color of mucin?
Eosinophilic.
Pale
I mean,
very pale, very pale.
Pale eosinophilic.
Not really be able to, if you see it, it's not, maybe there's a little bit of mucin. Sorry, I have to put the. One second. Okay, see, here maybe there's a little bit of mucin. Otherwise, the fovea are dilated. There's no mucin in that. What is this? Can anybody tell me? Nikita? Or
looks like abscess.
Actually, these are cells. This is an artifact. These cells have come from lower down. They've been squeezed by the biopsy forceps to come out into the lumen. Okay, so this is an artifact. This is not important. It's an artifact. So actually, these foveolae are just simply dilated. Then what else do you see here?
Dr. Anna, one question. Can we call this telescoping, or this is different?
Yeah, it is like telescoping of the contents of the glands and foveolae into the lumen of the foveolae.
Okay.
Okay. So Ravi, what else can you make out here? The fovulae are here, they're tortuous. Up to here is fovulae. Any comment about the glands? Nothing much to say. And what about the lamina propria?
The lamina propria shows a moderate degree of inflammation, ma'am.
Okay, quite a lot of inflammation. Okay. Now this is a higher magnification. What can you see on this magnification? What is happening here?
Intraepithelial
Intraepithelial?
lymphocytes.
And neutrophils.
Yeah, there are hardly any lymphocytes, mostly
Yeah.
neutrophils.
Neutrophils, yeah.
What is the terminology for that? When neutrophils infiltrate the foveolar epithelium?
Activity.
Pardon?
Neutrophil
Activity.
Yeah, that's termed activity, but what is the pathological term for that? Histological term. Whenever you have inflammation somewhere, what's it called?
Abscess. If
Abscess.
there is acute
Neutrophilic
inflammation,
abscess.
So abscess is when the neutrophils come into the lumen.
Yeah.
Foveolitis. This is called foveolitis. When neutrophils infiltrate the epithelium, it's called foveolitis. When neutrophils come into the lumen of the foveolae, it's called foveolar abscess formation.
Abscess.
So there are lots of neutrophils in the foveolae. So this is quite a severe foveolitis here. But in other foveolae, there is no neutrophil infiltration. So this foveolae has a lot of neutrophils. The other foveolae, this one has a few neutrophils. Otherwise, there are no neutrophils in the epithelium. And what about this epithelium itself? What is the normal color of the gastric epithelium? Is this how it looks? Is this how the normal epithelium looks? No, the normal epithelium has a lot of mucin. Can you see on this side where the pointer is? There's lots of mucin here. Okay,
Yes.
in this area, you're seeing lots of mucin. Here, there is some mucin. Here also, but on the surface, there's a mucin depletion. This is indicative of damage. Okay. Okay, now this is another area. You're seeing, what are you seeing in the lamina propria? Ankita? Ankita?
Ankita is not there, man. You can go.
Okay, fine. Sukanya?
Ma'am, inflammation, lymphocytes and plasma cells and
Yeah,
few
mostly
polymorphs.
chronic inflammatory cells. Okay, so actually for the definition of chronic gastritis, usually you have to have chronic inflammatory cells in the lamina propria. Okay, so what's your impression on this case?
Chronic gastritis.
Good, chronic gastritis
With focal activity.
with activity, good. Actually, we didn't see any atrophy, we didn't see any intestinal metaplasia, so it's just a chronic gastritis with with atrophy, with activity, sorry. Antral mucosal biopsy. Now, the ideal mucosal biopsy has to be full thickness. Okay, unfortunately, in our case, the biopsy was not full thickness. We didn't see the muscularis mucosa at the bottom. So it's difficult to assess atrophy accurately if you don't have a full thickness biopsy. And also you need to have sufficient mucosa to be able to evaluate all these changes. So ideally, they say each biopsy should be about 5 millimeter long. And also biopsies actually should be submitted separately from the antrum and the body for proper evaluation. And we'll be looking at that later on. And also finally in the lab, the tissue has to be well oriented and thinly cut sections so that you can make out things like neutrophils and what kind of cells are there. Now our biopsy, none of the fragments actually had muscularis mucosa at the bottom. Okay, so actually we cannot accurately gauge atrophy in this particular biopsy. So one question for anybody. What do you think is the most likely cause of this gastritis? NSAIDs, H. pylori, autoimmune, or bile reflux.
H. pylori
Okay, why do you say that?
because of focal activity, ma'am.
Activity, can you see in any other type of gastritis? Is activity seen only with H. pylori?
Um,
Activity can be seen in any kind of gastritis. Okay, anywhere where there's damage, you can get activity. So that is not actually the criteria for H. pylori. It helps, but it's not the main criteria. Anybody
Also,
else?
the antrum predominant
Yes, that's a
ulcer.
good thing. I mean, we can't say predominant because we don't have a gastric body.
Gastric,
We
yeah.
can say that
But
the antrum is significantly involved.
antrum,
Okay, so that
yeah.
is more like an H. pylori associated. Good. Any other feature?
Mucin depletion,
Yeah, that's a good one. But actually, any damage can cause mucin depletion. It's like activity.
depletion.
Activity, mucin depletion go together.
Yes.
Chronic inflammation. Okay, chronic inflammation is a feature of most commonly H. pylori associated gastritis. Okay, so the answer is H. pylori associated gastritis. So what special stain do you do for that?
Jibs.
Warthin study.
Autumn study.
How many people do Wharton study in their lab?
Okay, what is it?
Modified genes.
Modified genes. Why is Wharton study not used? It's very expensive. Wharton study is a silver stain. It's very expensive. Modified genes are very cheap stain. Okay, so that's the best and easiest stain to do. Okay, so to evaluate a modified genes stain, firstly, the section has to be good and you have to have the surface epithelium there or foveolar epithelium because that's where H. pylori are located. Okay, can you tell me some other features that help you diagnose that it is H. pylori? Nikita there?
Yes, ma'am.
Nikita, what are the features that tell you? Can you get any bacteria other than H. pylori in a gastric mucosal biopsy?
Yes, Loro.
Can you?
Stomach. Giardia.
Most
Giardia is a parasite. You don't commonly get it in the gastric mucosa. What about bacteria? Can you get other bacteria?
Strongyloids.
Strongyloids are also parasite.
amoeba, but that is also
Yeah, you can actually get other bacteria, ordinary bacilli, cocci, coccobacilli. All these things can be found on the gastric epithelium. So how do you make out whether these are really H. pylori or some other bacilli or coccobacilli? How will you make out? Anybody? Pfizer? So are these what you're seeing here? Are these H. pylori?
yes.
Why are they
Yes,
not
ma'am.
bacilli, regular bacilli? Why is it not E. coli?
Um,
Do you have to do culture to make out?
Ma'am, there'll be more in number, will be present in class. And
No, actually, even regular bacteria can be present in large numbers. Colonies of bacteria may be seen on the surface. You do see it sometimes. Especially patients
These-
on PPIs. Surabhi, how will you make out H. pylori from other bacteria? What's the most important feature?
Ma'am, their shape,
Correct. What is the shape?
they are usually spiral shaped.
So do you call the spiral?
Bacilli,
Is the spiral?
S
It's
curve,
an S
they're
shape.
more wavy.
Yes,
Yeah. Curvilinear, somebody has said in the audience. Good.
curved S-shaped bacilli.
Yeah, S shape is the most common. Sometimes it can look like a bird. Can you see this? How we draw a bird like a V. It may look V shaped. Okay, sometimes it may look like a comma. Only a little comma. I don't know
Comma
if you can make out this one. Just comma shape, S shape, V shape like a bird, open V, or rarely you can even get two spirals. Like, can you see this one looks quite long? Okay, there are two curves like that, two S's. But most common is a single S. So you have to see that curved shape in the right location that is on the surface of the epithelium, and it should be darkly stained. So if the mucus itself can form condensation which can resemble H. pylori. Can you see all these structures here? They can look like H. pylori. This is a slightly lower part. But still, the mucus condensation can look like H. pylori, but you have to see this dark, clear stain of a curved bacillus of this correct size and shape and location to say that it is H. pylori. Okay, and there is an immunohistochemical stain that you can use for confirmation if you see only a few bacteria and you're not sure that it's H. pylori. Okay, so the final diagnosis in this case is H. pylori associated mild chronic gastritis with moderate activity. So the updated Sydney system is the most accepted system for the evaluation and classification of gastritis. It's quite an old system, but actually it is very simple, and nobody has come up with a better classification system. So as of now, we still use the updated Sydney system, and even the Indian Society of Gastroenterology and Indian Association of Pathology Microbiology, we will all recommend using the updated Sydney system for the classification and grading of gastritis. So the important aspects of this Sydney system is, first you have to talk about which part of the stomach is involved. Okay, whether it's antral predominant, mainly in the antrum, mainly in the body, or involving both antrum and body. Then you have to look at the morphology of the mucosa. Are the changes only acute? Are the changes mainly chronic with some acute? Or are there any specific features that tell you this is a special kind of gastritis? These are things that we have to evaluate when we look at the mucosal biopsy. We also have to grade all the variables. There are certain important variables that tell you, and this is mainly in terms of H. pylori associated gastritis, but it's also useful in other forms. So they will tell you whether the gastritis is mild, moderate, or severe, whether all the other changes are mild, moderate, or severe, and also whether activity is mild, moderate, or severe. So grading the gastritis is probably helpful for clinicians when they are treating the patient. Dr. Desai, is there any situation where for you it's important that we grade any variable?
Meaning?
So like the different types of things that we see in the gastric mucosa we talk about in histology is activity, chronic inflammation, intestinal metaplasia, atrophy. So do you want to know whether these are mild, moderate, severe in any situation? Is it important for you to know whether intestinal metaplasia is mild, moderate, or severe?
Yeah, intestinal metaplasia, yes, because that decides our follow-up endoscopy.
Yeah. So management of the patient will be affected by how much of intestinal metaplasia there is. And usually that is correlated with the atrophy. So these are the main things that you have to grade. But in the Sydney system, we also grade the other variables. And then, of course, we have to look for the specific etiology of the gastritis, whether it looks like H. pylori, drug-induced, autoimmune, portal hypertensive, or other special forms. And I'll go through some of them. So the main common ones are H. pylori, drug-induced or reactive, autoimmune, and then less often portal hypertensive gastropathy. Certain specific types of gastritis are eosinophilic, lymphocytic, granulomatous, collagenous, or specific infections. By topography, we mean which part of the stomach is involved. So for the ideal description of gastritis, we have to have separate biopsies on the body and the antrum. And the Sydney system says that clinicians should take biopsies from the lesser and greater curve separately in the body, separately in the antrum, and one biopsy from the incisura angularis. Okay, this is the angle of the stomach between the body and the antrum. And they say that many types of gastritis start over here. Intestinal metaplasia also may start here first. So it's important to take a biopsy from here. this biopsy can be put into the same bottle as the antral biopsies, and the body biopsies should be put in a separate bottle. So ideally, we should be getting 2 bottles of mucosal biopsies. This is because the causes of gastritis that are predominantly in the antrum, what are they? Can you tell me 2 types? Pfizer? What kinds of gastritis will mainly affect the antrum? Tell me any 2. We already mentioned 1. Mainly the antrum?
Antrum predominant.
Which one?
H. pylori is mainly antral predominant.
More
Autoimmune
common
is
in the antrum. Any other type of gastritis that's antral predominant?
I'm not sure, ma'am.
Reactive gastropathy. What is reactive?
Chemical gastropathy.
Yeah, good.
NSAIDs-induced gastropathy.
Yeah, that's the same thing. Okay, and then you can get a multifocal gastritis that affects different parts of the stomach. Okay, multiple foci are involved. So which disease causes this? H. pylori. Okay.
H. pylori.
Yeah. And then you have the body predominant gastritis, where mainly the body is affected, antrum is spared. So which is the condition associated, which is seen like that?
Autoimmune
Autoimmune.
gastritis.
Yeah. Okay, good. Okay, and then we talk about the morphology of the gastritis. So which part of the stomach is affected? Helps us decide the etiology. And then we classify the gastritis as acute and chronic. Okay, acute, the changes in acute gastritis are what you would have read in Robbins in acute inflammation. Okay, vascular changes, neutrophils, and if there's very severe damage, erosions and ulcers. And in chronic gastritis, you have chronic inflammation, and the damage caused by that is atrophy and metaplasia. And sometimes you get a prominent stromal changes like fibrosis and vascular changes. Okay, and these are the variables that are graded, that are recommended to be graded by the Sydney grading system. So H. pylori, whether it's mild, moderate or severe, depending on how many bacteria. So when you look at this image, if you just see a few bacteria here and there, it's called mild. If you see lots of bacteria almost touching each other, moderate. And if you see them here piled up, it's marked. Okay, now this is not the best possible method of grading H. pylori or any of the variables, but it is one common method of grading them. And for want of a better methodology, this is what is recommended by everybody. Okay, all over the world. So you can look at this image, and which is a majority picture seen in your case, you will call it that. So if you see just a few everywhere, you'll call it mild. If you see mild in a few areas, but mostly it is this, then you'll call it moderate. If there are sufficient number of areas with this much of H. pylori, you'll call it severe or marked H. pylori infection. Similarly, this is how you grade the atrophy. Loss of glands, this is in the antrum and this is in the body. You see in the antrum how the spacing is a bit different from the body and the orientation. So in the antrum, just loss of 1 or 2 glands here and there is called mild. Greater loss is moderate and severe loss is marked. Okay, it's not, again, I'm not saying it's easy. Grading mild, saying mild atrophy is not easy at all. But one of the things that you can say is, if the space between 2 glands is more than the space of 1 gland. Okay, if you can see that here 1 gland is missing, then it is significant atrophy. If you look here, there is some space here, but it's not, a whole gland will not fit here. Okay, so the space between the glands, if it's more than a gland, that's mild. If it's 2, 3 glands missing, this between glands, that is called moderate. More than 3 glands lost in a row can be severe. Okay, that is one way of looking at it. But this is a visual analog scale. For the foveolitis and neutrophils in the lamina propria, this is the way they grade it. If you see a few neutrophils in the lamina propria, maybe 1 or 2 in the epithelium, it's called mild. If you have more in the epithelium and lamina propria, moderate, may go into the lumen. And this is severe. This activity is mild, moderate, severe. And this is chronic inflammation. The number of cells that you see between the foveolae is how you grade this. So here normally you may get 2 or 3 lymphocytes between the foveolae, but if you have more than that, it's mild, and then lots, and then this is very severe. Similarly, intestinal metaplasia, whether you see just 1 or 2 foveolae or glands, or adjacent foveolae and glands involved, or multiple adjacent foveolae and glands involved, that's called severe. And so then we said there's acute and there's chronic gastritis. So acute gastritis, it's not often that we see acute gastritis in mucosal biopsies, because usually clinicians will only do a scopy for patients who have a longer history of symptoms, not if they have 3 days history and things. So this is acute gastritis. What is the main feature you're seeing here?
Neutrophilic infiltration.
Neutrophilic infiltration and mucin depletion. Can you see that? The severe mucin depletion in the epithelium. There's no mucin at all. And also the lamina propria shows some hemorrhage, congestion, hemorrhage, neutrophils going out into the lumen. And so at this point, I'll just tell you that to diagnose an ulcer, you have to actually see loss of epithelium, but also in addition to loss of epithelium, like, is this a true ulcer?
No.
Epithelium is missing.
No, ma'am.
Why is it not a
No.
true ulcer?
Because
Absence
there
of
is no
granulation.
granulation tissue formation.
Okay, so granulation tissue you will see in an acute or chronic ulcer.
Chronic one.
Acute ulcer, what will you see?
Neutrophil.
Exudate, necroinflammatory.
Yeah.
Exudates.
Fibrinopurulent exudate, neutrophils and fibrin. That's what you
Exudates.
see. Okay.
Yeah.
So if there was neutrophils and fibrin here, we may suspect with neutrophils in the lamina propria. But here there's no exudate and there's no granulation tissue. So how do we get this in a biopsy? How does this happen?
It's artifactual, ma'am. Erosion.
What kind
just
of artifact
erosion
is
of the
it?
epithelium.
Cutting artifact.
It could be a poor orientation. Yes, correct. So that will be like a
Yeah.
cutting, embedding artifact.
And
Any
embedding.
other?
Yeah.
During the procedure.
Yeah, during the procedure, they may pull off the epithelium.
Procedure.
Okay. So then it can be artifactual. And chronic gastritis, you diagnose by the presence, firstly, most commonly, the presence of chronic inflammation. Okay, can you see here? This is how almost normal mucosa looks. Very few inflammatory cells. Here, there's a little bit more inflammation. Here, inflammation seems to be the main thing. Okay, here inflammation is superficial. Here, inflammation is going up to the muscularis mucosa. So this is significant chronic inflammation. And here there is loss of glands. You can make out here normal glands. Here there's loss of glands. And here, in addition to loss of glands, in the last one, there's also intestinal metaplasia here. Okay, so these are all the features of chronic gastritis, classic. Okay, so then the variable that we grade is activity that I showed you. And here you see foveolitis, neutrophils in the epithelium, not so severe as the one that I showed you before that, and neutrophils in the lamina propria. Okay, this is activity. Again, severe foveolitis here. Chronic inflammation grading, we already talked about that. And here you see a grading of the amount of inflammation. Here, there's hardly any inflammation. Here, there's a mild chronic inflammation. Here, there's moderate. And here, there is severe chronic inflammation. Atrophy of glands, this we already talked about. It can be difficult. And sometimes atrophy may be very focal. It may not be diffuse. Like here, just here, there is a loss of glands in this area associated with the lymphoid follicle formation. So that is focal atrophy. not a diffuse atrophy. Here, there's more of a diffuse atrophy. So in lots of areas, here there's loss of glands, here there's some loss of glands, here there is loss of glands. So this is a more diffuse kind of atrophy. Another clue to making out whether there's atrophy or not is by counting the number of glands in a vertical section. So there should be around 3 sets of glands in one section. 1, 2, 3. There's another one here. Here it's about 1, 2, 3. Here there are 2. So there seems to be but here there's only 1. Here there are 2 here, but here there's definitely a loss. So it's a combination of the space and the crowding of the glands and all that. So sometimes the atrophy is associated with intestinal metaplasia. Can you see that here? Extensive atrophy associated with intestinal metaplasia carries an increased risk of malignancy. So has anybody heard of the Olga staging system?
Yes, ma'am.
What is that?
Oh, just heard it. I mean, staging system for gastritis, ma'am.
Why do they use that? So normally in the Sydney system, we just grade it, mild, moderate, severe atrophy. But in the staging system, based on how much of atrophy there is in the body, corpus is also called body, and antrum, they stage it. So if you don't have atrophy in either, it's stage 0. If you have severe atrophy in both the antrum and the body, it's stage 4. So basically, stage 4 atrophy and stage 3 atrophy will have a higher risk of malignancy developing. So they've tested it and verified it, but still it's not become very popular because it's complicated for us. We don't always get biopsies from the antrum and body, and also then to grade it accurately and then to convert it into a stage is very complex. So even though it's recommended, most people don't use it. You have to be aware of it. So this intestinal metaplasia grading, we talked about that. The other important thing to know is that there are 2 types of intestinal metaplasia. Has anybody heard of complete and incomplete?
Yes, ma'am. Complete and incomplete.
Tell me. Surabhi?
When there is like a part of the gland fovea is replaced,
Good.
then it is
Called?
incomplete, and if it is completely replaced, then it is complete.
Yeah, so basically the entire epithelium is replaced, gastric epithelium is replaced by goblet cells and intestinal cells. It is called complete. When only there's a mixture of gastric and intestinal epithelium, it's called incomplete. So how will you make out? By histology, can you make out?
Ma'am, in complete, there will be more of tubular glands, whereas in incomplete, we'll see irregular glands present.
It's not the shape of the gland, but the epithelium that tells you.
Yes, ma'am.
Complete
Foveolar
cells.
type of epithelium will be incomplete cells.
Yeah, if you see foveolar type epithelium mixed with goblet cells, like here, it's called incomplete. Here, foveolar epithelium.
No brush border will be available. No brush border.
Where is the brush border evident?
Incomplete.
In the complete one.
Yeah. So this one actually has a brush border, and then you have goblet cells interspersed among the secretory cells that are absorptive cells which don't have mucin. Okay. And another feature of complete is you might see Paneth cells at the bottom. Those are intestinal epithelium. So what are the special stains we use for making out complete and incomplete?
Pass,
And
Alchin
Alchin
blue,
blue.
pass.
And any other stain? Is there any stain specific for large intestinal mucin? It's called high iron diamine. Okay, not commonly used. This is the stain with an Alcin blue background stain. So if you have large intestinal mucosa, epithelium, that will stain dark brown. Okay, this is the one that's said to be dangerous. The large intestinal type. And otherwise, what is this blue thing? Here also you're seeing blue. What is the blue? Ankita?
Goblet.
Is Ankita there? Okay, Sukanya?
Goblet cell.
What kind of goblet cells? What kind of mucin is seen in those? Why do we do alcin blue PAS? What is the difference between alcin blue and what this is blue, no? Alcin blue positive.
Acidic mucin will be
Acidic and
Good,
basic.
very good. So which acidic mucin comes from which part of the intestinal tract?
Antrum.
The gastric mucosa is all neutral. Pink. Okay, pink is neutral. Gastric. So if it's blue, it's intestinal. Either small or large intestine. Both small and large intestine will stain blue on alcin blue PAS. So how will you make out, is this complete or incomplete? And incomplete, you get both neutral and acidic.
Acidic.
Mixed. Okay, neutral of the fovula type. Okay, so this particular section shows you a complete intestinal metaplasia with Paneth cells at the bottom in a case of atrophy. And there's an Olga IM staging system like for atrophy. There's one for intestinal metaplasia also, but not very commonly used. Okay, so to summarize, case 1 was an H. pylori associated etiology, mild chronic or mild to moderate chronic gastritis with moderate activity of the antrum, no atrophy or intestinal metaplasia. So if you look at H. pylori, starts off with acute, though we don't see it, goes on to chronic, can either have an ulcer or just develop atrophy, intestinal metaplasia, and then the intestinal metaplasia can go on to a dysplasia and adenocarcinoma. The lymphoid follicles that form in H. pylori may go on to a malt lymphoma. Okay, H. pylori associated gastritis is quite common in some populations. In our population, maybe it's about 30 to 40%. Okay, some of them may develop peptic ulcers. Eradication of H. pylori prevents ulcer recurrence. Okay, if you don't treat the H. pylori, patients with ulcers will get another ulcer 80% within a year. Okay, coming to the second case. We'll start with, is Nikita, no, who has, okay, everybody I think has answered. Nikita, you want to start the case? 54-year-old male with dyspepsia, antral erythema. Biopsies from the antrum. Just describe what you're seeing.
There's more tortuous.
Yes, good. Fovulae are very tortuous.
Fovulae are more tortuous.
Okay.
And there's atrophy of glands.
See, is this a good biopsy for evaluation of atrophy? Can you see muscularis mucosa?
No.
Yeah.
No.
So when you don't see muscularis mucosa, I don't think we can accurately assess, because you need to see the full thickness of the mucosa before you assess atrophy. If you see only part of the thickness, you can't assess atrophy accurately.
And then there's mild intestinal metaplasia.
Okay, why you think it looks like intestine? Why? Okay, I'll show you a higher power picture. Is there really intestinal metaplasia?
No. There's hemorrhage.
Yeah, there's congestion.
Congestion is there.
Yeah, okay. What's the difference between congestion and hemorrhage?
Ma'am, congestion will
Congestion
be
is-
where hemorrhage will be
Within the vessel?
Within the lumen of the vessel. So it will be very clearly outlined.
Vessel.
If it's hemorrhage, it will be all outside, so it will be all irregular. You can't make out a clear outline. So this is all congestion. What else are you seeing here? Nikita, what are the things we have to grade other than H. pylori? What else do we grade? Activity. Is there any activity?
Then atrophy.
Okay, so we can't grade atrophy in this case. There was no intestinal metaplasia. What else is there left to grade?
Chronicity. Activity.
Activity, is there any activity?
No,
No, ma'am.
Not seeing anything.
No, ma'am.
Okay. What is the other thing we grade? Chronic inflammation. How much chronic inflammation is there in this case?
Mild.
Mild.
Yeah, mild or hardly anything, minimal.
Hmm.
Okay, so there's not much inflammation, but what else are you seeing in the lamina propria? What is this? What are these pink fibers?
My muscle.
Smooth muscle.
Smooth
Smooth
muscle.
muscle.
Smooth muscle.
And the background, what is all this? Pale pink.
Fibro.
Here.
Mucin.
Is the mucin inside the mucosa or outside?
Outside.
Outside.
This whole background looks pink. What is that? That's fibrosis.
Okay.
So there's fibrosis, smooth muscle upgrowth, congestion, very little inflammation. Foveolar hyperplasia. Okay, so what kind of diagnosis will this be?
Reactive gastropathy.
Okay, good. So the diagnosis in this case is reactive gastropathy. It's a very straightforward case. It's different from H. pylori, though both of them affect the antrum, but there's less atrophy, less intestinal metaplasia, less inflammation in reactive. But you get more of fibrosis, congestion, vascular telangiectasia, smooth muscle upgrowth. Okay, so this is H. pylori, lots of inflammation. This is reactive, hardly any inflammation. But there's foveolar damage. So reactive. Causes of reactive gastropathy, drugs, mainly NSAIDs, but other drugs, alcohol can cause. And bile reflux also can cause. Bile reflux from the duodenum into the stomach. Okay, this is NSAID associated gastritis is common in people who frequently use NSAIDs. Up to 10% of NSAID users will have ulcers and erosions. 1 to 2% of them will have major gastric bleed. Okay, if they are long-term users, 10 to 45% have reactive gastropathy. It's because of loss of mucus barrier and damage to the prostaglandins. Okay, so the changes are, as in the stroma, you get edema, erythema, congestion, friability, erosions, all of which you can see on scopy. But on microscopy, you get foveolar hyperplasia with epithelial mucin depletion, fibrosis, smooth muscle upgrowth, congestion, paucity of inflammation. Okay, this is reactive gastropathy. Okay, third case. We'll go back to Pfizer. Pfizer, 46-year-old male with anemia, pallor in the body on upper GI endoscopy, biopsies from the antrum and the fundus. Okay, this biopsy is from the antrum and this biopsy is from the fundus. Do you want to comment on anything at this low part? Liza?
Low power, yes, ma'am. There is this foveolar hyperplasia, I could say, ma'am, on
Okay.
low power.
See, why do you want to say
in
foveolar
antrum?
hyperplasia? How do you say foveolar hyperplasia?
Tortuous foveolae.
How tortuous are these? Slightly, they are a
Not
little
much.
bit curved, but not very tortuous. Okay, so that's
Tortuous.
not an important finding here. The foveolae are almost, they're showing some disarray, but they're normal. What
Okay.
about these glands? Are there enough
Glands are
glands?
yes, ma'am.
Okay. What about in the body?
Body, they are depleted.
Foveolae?
Foveolae are fine, ma'am, but glands
Yeah.
are depleted in the body.
Okay. And what about inflammation?
Inflammation is around moderate degree, ma'am.
Yeah. Good. Okay, so this is the antral biopsy, higher power. You see the normal component of glands, right? Here.
Yes, ma'am.
Foveolae is a bit curved, but otherwise, and the lamina propria shows only just a mild chronic inflammation. This is a body. What do you think, Faiza?
In the body, there is a bit more inflammation. Along
Okay.
with that, the glands are depleted.
What kind of glands do we expect to see? What color are the normal body glands?
Pale glands, ma'am.
Pardon?
Pale, ma'am. Pale
No,
looking
actually,
glands.
body will not be pale. Antrum is pale because of mucus.
Pink.
Body, remember we said parietal and chief cells. What color are
Yeah,
parietal
so
cells?
pink.
Pink.
Eosinophil.
Why are they pink? Okay, you don't have to know this. They're pink because a lot of mitochondria. That makes it pink.
Okay.
And the chief cells, what color are they?
Eosinophilic.
No, the chief cells are more bluish. Why? What do they produce? They produce enzymes. That's a protein. So why does it turn blue? Why are those cells blue? Lots of mRNA. Okay, for producing proteins, you need mRNA. So those cells have lots of mRNA, which makes it blue. Okay, so here, are you seeing parietal cells and chief cells?
Yes, ma'am.
Not really. We're not seeing parietal cells and chief cells. Instead, what are we seeing here? What type of gland is this? Body or antral type?
Antral type.
Antral type.
Antral type.
So do you normally get antral type glands in the body?
No, ma'am.
So if you get it, what does it mean?
Metaplastic.
Yeah, it is a pyloric metaplasia. It's
Metaplasia.
severe atrophy of the normal body glands with pyloric metaplasia. And then what is this?
Goblets intestinal.
Yeah, so there's a severe atrophy with pyloric and intestinal metaplasia.
Metaplasia.
Okay. So what's your impression now? What do you see in the antrum? Mild, moderate,
Antrum.
severe?
Mild inflammation.
Very mild. Okay. And body?
Body moderate
Okay. Other than inflammation
with pyloric and
Metaplastic.
intestinal metaplasia.
and atrophy, no?
And
So if you
atrophy,
have to
yes.
say by topography, what kind of gastritis is this? Antrum predominant, body predominant, or both?
Autoimmune.
Both.
What kind of topography
Body
is it?
predominant.
Body predominant, okay?
Yes.
So in the normal antral mucosa, you have this kind of glands, and our case had this, so this is not very, it's within normal limits. But in the body, this is how the normal body glands look. Okay, lots of pink parietal cells in the middle part and chief cells in the lower part. But in our case, there are no normal body glands. So it's a severe atrophy with pyloric and intestinal metaplasia. Okay. So severe chronic gastritis with severe atrophy, intestinal pyloric metaplasia, body mucosa. What special stains do we need to do on such a case?
Pars Alcian bloomer.
Okay, for intestinal metaplasia. Okay, which kind of intestinal metaplasia? That's good.
Incomplete.
Okay. Dr. Desai, do you ever ask the pathologist whether it is complete or incomplete? Is it important?
Yes. We always ask for it.
It's supposed to be important, but actually most people don't bother to differentiate. Okay, if you have the time and the inclination, yes, you can do the special stain and try to make out. But one of the problems also is you can get incomplete in one place and complete in another place. So just because you're looking only at one side, knowing whether it's incomplete or complete may not be the last answer. So more than finding out which kind of intestinal metaplasia, what else do you need to rule out in this case?
So, normally, it is in the colon and stomach only that we ask for it, actually.
Correct.
More in colon than this.
Yeah, the intestinal epithelium. Okay, so Surabhi, what special stains will we do in this case? So all gastric biopsies, you should do an H. pylori stain, modified genes. Okay, you need to do a GIMSA on all cases with inflammation, activity, atrophy, intestinal metaplasia. You have to rule out H. pylori. Always do a modified GIMSA. Any other special stains? I wanted to show you something else in this case. What are these cells here? Are they antral glands? Are they body glands? Do they look like some other cells that you've seen in other parts of the body? Any tumor cells? What tumor will look like this? What kind of cells? Anybody? Here. What cells can look like this? Uniform round oval nuclei, moderate amounts. Huh?
Neuroendocrine.
Neuroendocrine cells. Okay, so there is actually a proliferation of neuroendocrine cells here. So in addition to the severe chronic gastritis atrophy, you also will do an immunohistochemistry to identify the neuroendocrine cells. So normally you hardly get scattered neuroendocrine cells, but in this particular case, when we did the synaptophysin, you see these nodules, okay, corresponding to those cells that we saw. So in some areas, there's a linear proliferation of cells. See, this is the normal pattern of staining, like this. Scattered cells here and there, this is normal. But if you get a linear stain like this, or if you get small nodules, this is neuroendocrine cell hyperplasia. And it's common in autoimmune gastritis. Okay, so here you have, it's a body predominant, severe chronic gastritis, severe atrophy, intestinal pyloric metaplasia, and neuroendocrine cell hyperplasia of the body. Okay, suggestive of autoimmune etiology. Okay, now, what is the pathway for this neuroendocrine cell hyperplasia? When you get loss of parietal cells, acid production comes down. So, to stimulate acid production, gastrin is produced in the antrum by the G cells. This gastrin circulates through the systemic circulation and comes to the body. And here in the body, it will stimulate the endocrine cells that produce histamine. Okay, the cells that produce histamine are the enterochromaffin-like cells. Okay, these cells produce histamine and stimulate parietal cells to produce more acid. So it's just a cycle in the body where you're trying to produce more acid because there's loss of cells. So this is what produces neuroendocrine cell hyperplasia. And this neuroendocrine cell hyperplasia will start off as just increased cells, but eventually it can go on to neuroendocrine tumors. Okay, this is something you have to be aware in autoimmune gastritis. You get neuroendocrine tumors in the body of the stomach, but usually these are benign, but they can be recurrent and keep on coming, even if they're treated. But overall prognosis is good. Okay, so one question for anybody. Neuroendocrine tumors developing in autoimmune gastritis are found in 5% of all patients, found in end-stage disease, have more than 95% 5-year survival, all of the above. What do you think? Anybody?
All of the above.
Yeah. It is all of the above. Okay. Other useful tests for diagnosis of autoimmune are parietal cell and intrinsic factor antibodies. They also say low pepsinogen levels and high serum gastrin levels, but that's not so commonly done. And they can have both iron and B12. Classically, we talk about B12 deficiency, but that may come only at the end stage. Earlier stages, you can get iron deficiency. Okay, so phases are early, florid, and end stage. Early is, when it's only patchy involvement. Florid is when there's diffuse involvement. And end stage, almost all the glands are gone, extensive intestinal metaplasia, and ECL cell hyperplasia. Okay, next case, fourth case, a 16-year-old with chronic diarrhea. The CRP is slightly raised. Upper GI scopy was normal, but clinicians took biopsy from the antrum and incisura. Ankita, would you like to answer? This is a antral biopsy.
Ma'am, Ankita is not there. Maybe
Oh,
you
sorry.
can
Okay.
ask someone.
Sukanya?
Ma'am, foveolar epithelium lining the mucosa
Yes.
and few tortuous and elongated
A bit tortuous. Okay.
and lamina propria shows mild to moderate
Good.
lymphoplasmacytic infiltration and
Inflammation. Okay, that's good. We'll go to a higher power. What else are you seeing here? Can you see these cells here in the epithelium?
cryptitis.
Yeah, foveolitis.
Uveitis.
Yeah, so there's some activity also going on here. So there's chronic inflammation and activity. This is these are other areas. Here, what are you seeing? Is there any loss of glands?
Yes, focal loss of
Glands here also.
yes, ma'am.
And instead of glands, what are you seeing here? Something pink?
Yes, ma'am.
Yes.
What could that be?
Necros.
Here, this. How do you describe these cells?
Granuloma.
More granuloma.
Granulomas. Okay,
Epithelioid
it's
cell.
very defined. There's no lymphoid cuff. It's kind of an ill-defined granuloma, funny shape.
Ill-defined granuloma, yeah.
Yeah, okay. So there are granulomas also in the lamina propria with granulomas. So what's your impression? Can you make a specific diagnosis or will you give a descriptive diagnosis?
Ma'am, we can think in the lines of Crohn's since it's granuloma.
Why did you say Crohn's?
Presence of granuloma, ma'am.
What about TB?
Granulomatic gastritis.
Yeah, so when you can't make out, like you can't really make out on this biopsy whether it's TB or Crohn's. So you should just stick to a descriptive diagnosis. Either granulomatous gastritis or chronic gastritis, focal activity, focal atrophy, and granulomatous inflammation. So to say that it is Crohn's disease, you need more evidence. Okay, to say that it's Crohn's or TB, you need more evidence. So what evidence will tell you that it's Crohn's disease? What evidence do you need? What can you ask for?
Ma'am, skip lesions, presence of any skip lesions.
Okay, but actually you can get that in TB also.
Ma'am, site.
Only if you have a resection. So we will not ask them to resect the stomach, right? They won't. The patient doesn't even have any lesions in the stomach on scoping.
Ma'am, site of Crohn's is different. I mean,
like what?
Proximal ileum.
Actually, on a gastric biopsy, it's very difficult to differentiate TB and Crohn's. Unless you see caseation or acid-fast bacilli, for sure you can't say that it's TB. So you can have an early TB lesions which don't have necrosis or AFB. So you cannot really make out the difference. So you have to wait to see whether there is any other proof of Crohn's disease in any other site. Okay, so what is the other site that the clinicians can biopsy to help us make a diagnosis?
Small intestine and colon.
Okay, so this is a differential diagnosis of granulomatous gastritis. There are so many causes. Infectious TB, histoplasma, anisarca, syphilis, Whipple's, even H. pylori, some people say can cause granulomatous gastritis. Non-infectious Crohn's, sarcoid, foreign bodies, any food material going into the mucosa can cause granulomas. Vasculitis, we've seen granulomas associated with lymphoma, carcinoma, and then there's a disease called chronic granulomatous disease. So many diseases are there and we can't really make out between all of these. Okay, we can only say it's a possibility. The only thing is that in this patient, This was the ileal biopsy. What do you see? The villus is a little bit blunted, and you're seeing some histiocytic aggregate here, vague aggregate. Okay, and in the colon, there's a mild disarray of the crypts, mild chronic inflammation, and then what is this?
Granuloma.
Granuloma in the minor propria.
This kind of diffuse granulomas in the upper and lower GI tract, and not very severe disease, no caseation, no acid fast bacilli, hardly any confluent, no large granulomas, no ulceration with granulomas. All these features that differentiate TB from Crohn's are not there. So it's more towards a Crohn's disease. Okay. So in the stomach, what are the most common microscopic lesions in the gastric mucosa affected by Crohn's disease? Anybody?
Aphthous also.
Aphthous ulcer.
Anybody else? From the audience, nobody has written. Somebody has said granulomas. Somebody said lymphoid follicles. Most people are saying lymphoid follicles, but lymphoid follicles can be seen with H. pylori also. Aphthous ulcers actually are not specific for IBD. C.
Focally enhanced.
Focally enhanced gastritis. So what is focally enhanced gastritis? This is the answer. The most common microscopic lesion in the gastric mucosa in Crohn's disease is focally enhanced gastritis. Okay, so gastric Crohn's can be part of a symptomatic involvement or asymptomatic. Most patients with gastric involvement in Crohn's are asymptomatic. Okay, symptoms of the small intestinal and colonic involvement are more common. And on scopy, you may see aphthous and serpiginous ulcers. You may see outlet obstruction if it's very severe. Otherwise, just erythema, edema, or even like in our case, there was no scopy finding. So in gastric Crohn's disease, the earliest lesion is focally enhanced gastritis, which is small collections of lymphocytes and histiocytes around a group of gastric foveolae or glands, often infiltrated by neutrophils. So here you see these glands are infiltrated by neutrophils, and there's increased inflammation around these. So inflammation is enhanced in this particular focus. It's seen in up to 30 to 40% of patients with Crohn's, more common in the body than the antrum, more common in children than adults. Granulomas, on the other hand, may be seen in only 10 to 15% of cases and may be more common in the antrum than in the body. Okay, the only problem is focally enhanced gastritis is not specific for Crohn's. It may also be seen with H. pylori associated, which is actually a more common condition, may be seen in ulcerative colitis and following bone marrow transplant. So just because you see this again, you don't diagnose Crohn's, but if you see focally enhanced gastritis and you see granulomas and you have unexplained inflammation, no H. pylori, then you can start suspecting Crohn's disease. So you can tell the clinician, please investigate for Crohn's disease. Okay, so coming to our last case. Nikita?
Yes.
51-year-old female with epigastric pain and loss of appetite for quite a long time, 2 years. Scopy showed diffuse nodularity of the gastric mucosa, loss of the normal gastric mucosal rugae, poor distensibility, some kind of a diffuse disease, biopsy from the body and the antrum. Okay, now this is the biopsy. Nikita, you want to comment on this? Is there inflammation?
Ma'am, there is loss of foveolar epithelium.
Okay,
And,
there is some loss of foveolae, yes. What about glands?
Glands are
Here. Are you seeing normal glands here? Okay, here.
no, ma'am. Glands are
This area?
there is lymphoid follicle,
Yeah.
and there is fusion of glands at
Yeah,
places.
so actually more than fusion, it's a dilatation of the glands, but the normal component, remember I told you, you have to get 3 layers of glands.
That is missing.
There is 1, 2, 3, but here there's only 2. Here there's only 1. And here there are no glands. So there's definitely some atrophy.
Atrophy of the glands is
Yeah.
there.
And chronic inflammation. Not really seeing any metaplasia, right?
Yes, ma'am.
Okay. So this is another image. What else are you seeing? Is the surface epithelium okay?
No, it's
Ulceration.
ulceration is there.
See, if you want to say ulceration, you have to either have a acute inflammatory exudate or granulation tissue. Are you seeing either of them?
No, ma'am.
No, there's erosion along.
No, it's
and
actually just an artifactual loss of the epithelium. See, when you see a straight line on the top, that can't be an ulcer. An ulcer can never have a straight line. It will be irregular, the surface. So this is actually an artifact. This epithelium is getting peeled off. See, here it's come off.
Yes, ma'am.
Here it's come off. So it's an artifactual loss of epithelium. Actually, in this case, the surface epithelium is very fragile. It's just coming off. So what else is abnormal in this case? What are you seeing here? Is this normal?
No, ma'am.
What is this pinkish material here? Is there a kind of deposit here, pinkish deposit?
Fibrin.
Below the surface epithelium? Okay, fibrin is one option. Is fibrin usually darker than the epithelium or lighter than the epithelium?
Dark.
Darker. And also, how does it look? If you see fibrinous deposit, how will it look here? It will look like fibers, okay, or fibers clogged together. Dark pink.
Amyloid.
Yeah, so somebody in the audience also has said amyloid. It could be, that's definitely a possibility. So now what special stains would you do? So your impression here is
Congo red.
chronic gastritis, focal atrophy, and eosinophilic subepithelial deposits. Okay, what stains will you do?
Congo red.
Congo red is one.
Yeah, so what is the differential diagnosis for amyloid? Pink deposits, pale pink deposits. If it's not amyloid, say in the vessel wall, in the lamina propria, you see pale pink deposits. Either it can be amyloid or it may be. Correct. Somebody in the audience has said collagen. So it could be fibrosis. Okay, so the stain that you use for fibrosis is Misson Strike. What color will the collagen be? In trichrome stain?
Blue.
Bluish.
Okay, so is this positive? This is blue enough.
Yes.
Yes. This is blue. Here there isn't much of the deposit. And this is a Congo red. Is this positive or negative?
Positive.
Actually, in Congo red, if the stain is the same color as the background,
that is negative.
Okay, it's negative. The stained area should change in color. See, actually this artifactual here this is more like how Congo red will be positive. It's called salmon pink color. It has a more pinky color than the orange background. See, this is all orange. This is not any different from the epithelium. So this is actually a negative Congo red. So now what is your impression? Collagen deposition.
Collagenous gastritis.
Collagenous gastritis. Okay, so that is the final diagnosis in this case. So in collagenous gastritis, the collagen band below the surface epithelium has to be at least 10 microns thick. How will you evaluate the 10 microns? How will you know whether it's really 10 microns or not? What can you compare it with? What's the size of an RBC?
Slide with 7 microns.
7 microns. So you look at the RBCs in the mucosa and you see whether it's at least 1.5 times more than that. Okay, so more than 10 microns. Causes of collagenous gastritis, it may be autoimmune, it may be drug induced, maybe seen in children or adults. Can cause anemia or abdominal pain. On scopy, you see nodular mucosa. Okay, it can progress to collagenous enterocolitis. It may involve the stomach, small intestine, and colon. Okay, or it may be associated with lymphocytic enteritis, lymphocytic colitis, or it may be associated with other diseases like celiac disease. Okay, so the subepithelial collagen band may be 10 to 25 microns, irregular. It has the specific finding of collagenous gastritis is that capillaries and fibroblasts are embedded in the pink material. In amyloid, you don't have anything embedded in the amyloid. Okay, I'll show you a picture of that. So here, you see this is a fibroblast. Okay, this is probably a capillary. This is a fibroblast. This is probably a capillary. So within this collagen band, you have the fibroblasts and capillaries embedded. So that is how you diagnose on histology collagenous versus amyloid. In amyloid, it will be a thick band or it will be in the vessel walls. Okay. So to summarize what we've done today, we've looked at inflammatory lesions of the gastric mucosa. And we've said that when you look at a biopsy, you must identify which part of the stomach is affected if the clinician hasn't given it to you in separate bottles. So is it the antrum? Is it the body? And then you have to grade the variables and try and make out, is it acute? Is it chronic? And how severe is the chronic gastritis? And then, of course, you look for specific etiological factors, whether it's H. pylori, whether stroma is affected more than the inflammation. Look for granulomas, eosinophils, basal membrane changes, whether it's body predominant, antrum predominant. And we use the updated Sydney system for the classification, acute and chronic. The most common chronic ones are H. pylori associated, autoimmune and reactive. We've seen all three, and we've looked at two of the special forms also, which are granulomatous and collagenous. But you can get a lymphocytic gastritis where it's mainly increased lymphocytes in the epithelium, or you can get an eosinophilic gastritis where it's mainly eosinophils in the lamina propria, or you can get specific infections, specific viral infections. Rarely you can get cryptosporidia, CMV, all this, even strongyloids in the gastric mucosa. So your final report, you should talk about the etiology. So if it's H. pylori, you'll say H. pylori associated. And then you'll say acute or chronic gastritis, and antrum predominant or body predominant. Or you can say, if you have only one site, you can say H. pylori associated, moderate chronic gastritis. And in the morphology, you'll say with mild activity, mild atrophy, no intestinal metaplasia, comma, antral mucosal bulbs. Okay, so you've included in your final report both the etiology, the morphology, and the site of involvement, the topography. Okay. Any questions?
Thank you so much, ma'am. That was a very well explained session. We have few questions in the chat box.
Okay.
The first one would be, please explain foveolar hyperplasia on a slide.
Thing is, foveolar hyperplasia is probably one of the least important findings in gastritis, except in reactive gastritis. So you do not diagnose a reactive gastritis without seeing foveolar hyperplasia. So in normal foveolae look like this. Okay, they're straight, vertical, with plenty of mucin. So they look light pink. The cells are tall columnar. So straight foveolae in the body is one-fourth of the thickness. Okay, in the antrum, it is almost half the thickness. So if this is the full thickness of the antrum, the foveolae are reaching up to here, about 50% of the thickness. Okay, this is the normal epithelium, tall columnar, full of mucin. Okay, now
Next, ma'am.
Okay, this is the most severe form of foveolar hyperplasia I've got here. So there's severe mucin depletion. You're not seeing any mucin. You're seeing significant tortuosity. Significant tortuosity. So tortuosity, loss of mucin here. This is also, the loss of mucin here is less severe, but it's still there. and there is significant tortuosity, and there'll be an increase in the height. Okay, so here very high, tall foveolae. All these be foveolar hyperplasia.
Right, ma'am. Next, we have when there's a lymphoid aggregate, do we say it's atrophy at that site?
So when there's a lymphoid aggregate, you have to see, has the lymphoid aggregate pushed all the glands away from that site? Okay, here. So here there's a lymphoid aggregate, but here there are normal glands, and here there's a paucity of glands. So if this lymphoid aggregate has formed itself between the glands, there should be more glands on both sides of it. But here there is a loss of glands in addition to the lymphoid aggregate. So loss of glands should also be evaluated not just by this gap, but also whether, how many layers and how much is the gap. And if this lymphoid aggregate has just pushed the foveolae to both sides, the glands, there should be more glands on this side and this side. So this is actually a lymphoid aggregate associated with significant atrophy.
Next is, can we say reactive gastropathy without history?
Without?
History.
Yes, you can, no, because if you don't see inflammation, if you see fibrosis, smooth muscle upgrowth, no inflammation, how can it be H. pylori associated? How can it be autoimmune? So no inflammation, fibrosis, smooth muscle upgrowth, congestion, and lack of inflammation with foveolar damage and foveolar hyperplasia. This is reactive gastropathy.
Next is how to differentiate between neuroendocrine hyperplasia versus tumor in a biopsy.
Okay, so actually for that, the definition is how big the clusters are. So if the clusters are less than 150 microns, it's hyperplasia. If the cluster is more than 150 to 500 microns, they say that is dysplasia. If it's more than 500 microns, a half a millimeter, the whole cluster of neuroendocrine cells, then it's a tumor, benign tumor.
Next is, does RUT positivity always mean association of H. pylori infection?
So the problem with H. pylori is it can be very mild, it can be very patchy. So it's possible that in the endoscopic biopsy that they use for RUT, there was H. pylori or no H. pylori, but in your biopsy, it may be the opposite. So it is possible to have a discrepancy between RUT and H. pylori and biopsy. It is possible.
Next is, what is surface maturation?
Surface maturation is a feature that you use for the differentiation of dysplasia from regenerative atypia. So when you have normal surface epithelium with sufficient mucin, no crowding, tall columnar cells, no atypia, no hyperchromasia, no pleomorphism, that's normal surface maturation. That is?
Sorry.
Okay, so normally the stem cells in the gastric mucosa lie at the base of the foveolae. So the stem cells reproduce like here. This area will be stem cells. This area will be stem cells. So stem cells multiply and then they start becoming mature cells. As they mature, there's more mucin. So by the time you reach the surface, there should be plenty of mucin. Most of the foveolar cells also will have a lot of mucin. That is the normal maturation. Towards the glands also, the cells will mature. In this area, there may be lack of maturation. That's what you're seeing here. Here, you're not seeing so much of mucin. Here, you see more of mucin. Here. That's surface maturation.
Right, ma'am. Next is, what is the importance of complete and incomplete intestinal metaplasia?
So they say that incomplete metaplasia has a higher risk of malignancy, dysplasia and malignancy.
That's about it. There are a lot of praises in the chat box.
That's a very important thing because, finally, the reason why you do gastric biopsies is to see if there's any evidence of intestinal metaplasia, how severe it is, and if it has become dysplasia or malignancy. But of course, it's very, very, very important for us to diagnose H. pylori on a gastric biopsy because it's the only thing that clinicians can actually cure in a patient. So if you tell them there's H. pylori and they treat the patient and the patient is compliant and responds to treatment, then you've cured that patient of a chronic gastritis, which could have potentially gone on to malignancy. Very important to diagnose H. pylori also.
Right. And that's about it.
Yeah.
Yes, ma'am. There are a lot of praises. Thank you for much excellent teaching session. Enjoyed learning and especially the beautiful histopath slides.
Thank you.
Everyone's like thanking you.